demography, so that we can appreciate the person that the endocrinology pharmacist group is bringing to anchor today's presentation. She's actually a researcher who has made publication in different international journals. She was once the African representative on the board of Family Impact. She also chaired the Drug Information Center of the Association of Community Pharmacists of Nigeria for 9 years. She was also the coordinator of the Volunteer for AIDS Scripture Union in Lagos. She's also a fellow of the Commonwealth Professionals. And as you all know, she's also a member of many professional groups such as CPAN, WASPEN, NSTM, ISTM, and ADA. And she's also an active community pharmacy practitioner for over 3 decades. This I will testify from the experience we had with her during our PharmD specialty conversion program in Nsukka in 2019. And also she has a passion about rational use of medicine and preventive health. I would like to also inform us that I had a personal contact with this wonderful presenter during our special PharmD program, and sincerely speaking, she's actually a blessing to this profession. I would like to really appreciate everyone of us to listen attentively for today's presentation, which is on screening as a strategy for diabetes prevention. Ma, on behalf of all of us present today, I want to welcome you for today's presentation, while giving you the opportunity to present your program, Ma. Thank you, Ma.
Thank you very much, sir. Thank you, distinguished colleagues. Privileged to take us through this tonight. And what I've tried to package here is practical. I want it to be as practical as possible, because at the end of it all, we should be able to do more than we have been doing before. And it will also be a forum for us to interact and look at ways forward. So I'm asked to talk about screening as a strategy for diabetes prevention. I don't know where okay. So my outline is just as I have shown you. There will be an introduction. We have learning objectives. We look at diabetes overview very briefly, risk factors, diagnosis, screening, and then prevention. Then I will conclude. So let's look at global picture of diabetes. Sadly, 537 million adults are currently living with diabetes globally. And we are told that by 2030, this may increase by 20%. In 2021, diabetes claimed a life every 5 seconds, meaning that, I don't know, by the time we are done with this program, you can imagine how many lives would have been lost if this trend continues. Then 541 million adults have impaired glucose tolerance, and this number is increasing rapidly. And then we'll look at the link between impaired glucose tolerance and diabetes as we go along. So let's come to Africa, where we belong. In Africa, 24 million people are living with diabetes. 1 in 2 people living with diabetes in Africa are yet to be diagnosed. In 2021, diabetes claimed at least 4 lives every 5 minutes. And we are told that Africa has the second lowest diabetes-related expenditure, because of the economic situation in Africa. We don't have much money to cope with this big monster that is staring us in the face. So let's come home more. Let's look at the Nigerian picture. Currently, about 1 in every 27 adults has diabetes. That means that if you know how many people walk into your community pharmacist or your hospital pharmacist, and you know how many people you come in contact with on a daily basis, you can imagine how many are likely to have diabetes. And we are told that about 50% of them are undiagnosed. That means that irrespective of this figure, we still have another 50% somewhere that are yet to know that they have diabetes. In 2021, diabetes claimed 48,375 lives in Nigeria. And diabetes costs us $500 per adult living with diabetes. I intentionally left it at the dollars because we know that dollar to naira we can't predict. So if I did a conversion earlier, by now it might have changed. So what we want to do, we want to identify factors predisposing people to diabetes. We want to find out our roles in fishing out those at risk of diabetes. And then we want to learn the various ways by which we, as pharmacists, can help people at risk of diabetes from developing diabetes or delaying development of diabetes. It's very possible to prevent diabetes from developing. So what is the problem on ground? Pre-diabetes individuals with a higher incidence of CVD. We are told that about 20% of those who have pre-diabetes are likely to come down with CVD risk. I read that in one of the research papers I looked at. Many of the comorbidities associated with diabetes and future progressions to diabetes has pre-diabetes as an underlying factor. Pre-diabetes will progress to over type 2 diabetes in approximately 25% of subjects within 3 to 5 years. And as many as 70% of individuals with pre-diabetes will develop over diabetes within their lifetime. This is a work done by Osterlek, Ulrich. The reference is in my reference chart. According to a recent meta-analysis of 59 prospective studies in Nigeria, it was found out that one, the overall full prevalence of prediabetes in Nigeria was 13.2% using the American Diabetes Association criteria and 10.4% using the WHO criteria, translating to 15.8 million and 12.5 million adult pre-diabetic individuals in Nigeria using the AIDA and WHO criteria respectively. So as we stand, if we use the AIDA criteria, about 15.8 million Nigerians are pre-diabetic. Pre-diabetic individuals have almost 6 times the risk of developing diabetes than those who have normal glycemic index. So let's look at, I don't want to bore us tonight with overview of diabetes because we already know, we know a lot about it, but because we are talking about diabetes, we just brush it. So diabetes is a chronic metabolic disease characterized by elevated levels of blood sugar. And it occurs when the body is unable to produce enough insulin or deficient in its use of insulin. So we have basically, generally, 3 types of diabetes: type 1, type 2, gestational. And in type 1, we know that the body doesn't generate sufficient insulin for. In type 1, the body does not have the insulin. The beta cells are not functioning. In type 2, it's insufficient. And body is not able to produce enough insulin for regulation in pregnancy. That makes it gestational diabetes. And the symptoms might be there or not. Sometimes the patients come in, there's no symptom of diabetes whatsoever, and you might find their sugar level being astronomically high. So let's look at this slide that is talking about the diagnosis of type 2 diabetes, because tonight we want to focus more on type 2 diabetes, which is the more common. So we look at this slide, and we can see from the slide that we have 3 major tests here: the A1C test, the fasting blood sugar test, the glucose tolerance test. Diabetes is said to occur at 6.5 or above for A1C. Fasting blood sugar test of 126 milligram per DL or above is also regarded as diabetes. Glucose tolerance test of 200 milligram per dl or above is also regarded as diabetes. And then the pre-diabetes is when you have 5.7 to 6.4% of A1C, fasting blood sugar 100 to 125 milligrams per dl, or glucose tolerance test giving you 140 to 199 milligrams per dl. And the normal is when you have A1C below 5.7, fasting blood sugar test 99 milligrams per dl or below, glucose tolerance test 140 milligrams per dl or below. You will agree with me, for those of us who are actively in practice and see these patients, that sometimes you do just fasting blood sugar and it can be misleading. You might get a fasting blood sugar that looks normal and you think the patient is okay, but it might have been influenced by what that patient ate that day. So it's always necessary, if we can, as much as we can, to do more than fasting blood sugar tests to assess our patients. So let's look at the risk factors so that we'll know how we want to help people from prevent development of diabetes. When we know the risk factors, then we can look for ways to handle these risk factors. And I've tried to put them in non-modifiable and modifiable groups. Of course, we can do nothing about family history, the gender. Males seem to have higher risk, and then females with history of gestational diabetes to have higher risk. Then race, African Americans, Latino, Hispanics, Asians, Native Americans has higher risk for diabetes. Then the modifiable ones, sedentary lifestyle. We know that diabetes and poor exercise go hand in hand, sort of. Being overweight, if anybody that has weight that is 20% higher than what that person's ideal body weight should be, is at risk of developing diabetes. Then another parameter is the waist circumference. In men, we don't expect the waist circumference to be more than 94 centimeters. The more it is at 94 centimeters or more, the higher the risk that that person will come down with diabetes. And for women, except they are pregnant, we also want it to be below 80 centimeters. Then hypertension, we know, is a risk factor. And that means that everybody that has hypertension is a suspect for diabetes. People with metabolic syndrome, especially where they have 3 or more of those syndromes, they are likely to develop, or they are at risk for diabetes. Certain drugs too may predispose people to diabetes, like high dosages of corticosteroids. We know those ones can predispose people to diabetes. And of course, the pre-diabetes, which is the most common factor that we have. Now let's look at roles of the community pharmacist. And one is a major role in diabetes generally is prevention. And that prevention is in 3 stages. We have the primary, whereby we should, or we are expected to, and some of us who are opportune are screening for at-risk individuals. So primary prevention, we are screening for those who are at risk of developing diabetes, those who are not yet there. We want to prevent them from getting there. The secondary prevention is to prevent or delay development of complications for those who are already diabetic or yet to be diagnosed, and those at risk of developing complications. So at the secondary level, there are people who are already diabetic and they are yet to be diagnosed. We want to prevent them from developing complications by helping them to discover their status early enough for intervention. And then those who are at risk of developing complications, those who are already there too. And then the tertiary, we want to prevent consequences of complications if they've already occurred. And of course, we do that through lifestyle and ensuring rational use of anti-diabetic drugs. So tonight, we want to focus more on prediabetes. Like I said, as much as possible, I want us to focus on what we can do practically and how we'll go about what we will do. So I'm trying to make this presentation as practical as possible for all of us. Everybody should be able to position themselves in what we are doing tonight. So we will focus on our roles as pharmacists in prediabetes. And the key role is to educate. We need to increase awareness. Many people don't know what is called prediabetes. And except we create awareness around there. Just a day or two back, I had this patient that came in and she had some form of neuropathic pain. She had never been diagnosed diabetic. And by the time I clocked her, I found out that she had family history. Her father was diabetic. She was in her early 60s. So, and she told me her fasting blood sugar was 90 thereabouts. So I said to her that, look, there's a way we have to find out. Let us do your HbA1c. And she agreed to do it. And it turned out to be 7.1. So we need to also encourage people to screen, HbA1c testing, prediabetes risk test. We will talk about that later. Then we should enroll, well, I called this from, I call this out from US platform, CDC. So they have National Diabetes Prevention Program. So they encourage that pharmacists should enroll their pharmacy in pharmacy-led National Diabetes Prevention Program or refer to local National Diabetes Prevention Program provider. We don't have that here, but tonight we want to look at what can we do despite that we don't have this in Nigeria. What can we do? Because we just have to start changing the narrative. So these are also materials I called out from there on creating awareness on prediabetes. It is known that 9 out of 10 adults who have prediabetes don't know that they have it. That's huge. That means that just about 10% of those who have prediabetes know. So this flyer is saying 9 out of 10 adults who have prediabetes don't know they have it. It could be one of them. And when people see this flyer, they are likely to want to ask questions. So this is a way to get them talking. Though this is talk with your doctor, but we can have our own flyer that we say talk with your pharmacist, because we know that we can do a lot to help them. And there's another flyer that says prediabetes, are you at risk? And then it talks about what prediabetes is. I'm sure many people will be happy to want to find out if they are prediabetic, if they have the understanding that prediabetes can be treated. Prediabetes can prevent them from getting into diabetes or delay the onset of diabetes. And that is why we need to create a lot of awareness there. We need to talk to people. We need to let the public know that there is a good news hanging around them if they are pre-diabetic. And that is that they can be treated. So there's a pre-diabetes risk test that I stumbled on, and this is from the National Diabetes Prevention Program. By this, you assess numerically the risk of the person developing pre-diabetes, and there are figures that are assigned to each question. I know that sometime last year, thereabouts, we worked with Sanofi to develop some things along this line. So this one says, how old are you? And depending on your age, you get your points, because we know that age is a risk factor. And because also gender is a risk factor, if you're a man or a man gets a point, a woman 0. The less your points, the less your risk. If you're a woman and you have ever been diagnosed with gestational diabetes, then you get a point. That means it's just your risk is like that of a man. You have a mother, father, sister, or brother with diabetes. If it's yes, you get a point. And in our own climate, it is important that we break it down. We should not just say, do you have family issues? Because some of them don't understand what it means. You know, the way we see family here, somebody that is just your relation is regarded as family. So we need to ask questions. We need to let them know, is this your mother, your father, or sister, or brother? Then if the person has ever been diagnosed with high blood pressure, the person also will get a point. If the person is physically active, it's 0. If the person is not physically active, it is 1 point. Then the weight category now, they have varied points depending on BMI now. So this is a ratio of height and weight. We have to position them there to get the points. The higher the BMI from the normal, the more points that the patient will score. So by this score, anyone who scored 5 or higher is at increased risk for having pre-diabetes and at high risk for type 2 diabetes. But then the person needs further screening. This is just to give us an idea. And it's good to always let them know that we can mitigate this risk. There's something they can do to reduce the risk. So I also saw this in Elsevier, and this is like an algorithm to intervene in somebody who has pre-diabetes. So we identify patients at risk of pre-diabetes or diabetes. If the score, like we looked at in the previous slide, if the score is below 5, that means there's a low risk. Then we can reconsider rescreening every 1 to 5 years. But if the score is 6 to 11, intermediate risk, or greater than 12, that's high risk. And then it breaks it down to fasting glucose or HbA1c, then fasting glucose or 2-hour oral glucose tolerance test or HbA1c. And we can position our patients in any of these. And then the results will let us know if this patient is pre-diabetic or they are likely to have diabetes. And then we can do further tests. And this test can be done yearly or once in 3 years. So this is another test to assess for type 2 diabetes. And this assesses risk factors. I mean, the risk factors are taken into consideration here. So this is a bit more elaborate than the one that was testing for just pre-diabetes. So we have here age, body mass index, waist circumference is built in, exercise, then food intake is factored in, if the person takes vegetables or fruits or berries, and then if that person is on medication for blood pressure or not, the person has ever been found to have high blood glucose, or if any member of that person's immediate family or relative has been diagnosed. So all of these have been factored in here. And well, this test just gives us idea. We know that until we look into the blood, we are not likely to be able to draw conclusions, but these instruments have been used and they have some degree of sensitivity. So when the patient is pre-diabetic, what do? We need to counsel that patient. And it's majorly a long lifestyle. Later on, we will talk more about what to do with the patient that is pre-diabetic, apart from counseling. So it is important that, because as you know, it's multidisciplinary, we cannot handle it alone as pharmacists. So we might need to do some referral. And in the US, where I called this out, this is the way their own referral system goes. They enroll the patient in lifestyle change program. Then the patient is referred to lifestyle change program. The referral is received, then an enrollment is done. If an enrollment is done, it goes down that way. There's a weekly and then monthly lifestyle change program sessions. Then they provide regular feedback to clinical care team on the progress. And then there's updates on medical record with feedback on patients' progress and outcomes. If enrollment is not done, then we will notify the clinical care team that this person did not enroll for lifestyle change. And then we need to update medical record with the patient's enrollment status. It has to be on record so that another means of following up that patient can be devised. Now, where the patient is participating, if the patient completes lifestyle change program, it is a yes, we notify clinical care team and then we update. If it's no, we are still going to notify clinical care team and update the record. I brought this out so that we can appreciate the value of documentation in this work. Because at the end of the day, these documents will affect policies that will come up. And in our climb, we can start in our own little ways to make documentations that will help us to take informed decisions over time. So I'm challenging us this evening in this team to have some critical thinking through all of this. At the end of this session, as we go on, let's come together and look at ways that we can improve what we do. What can we also bring to the table in terms of helping people, preventing them from developing diabetes, in terms of documentation, in terms of us collaborating with other healthcare professionals. All of this will help us to be able to track or follow up on the patient. I recall a patient that visited some time ago, and I was not on duty. The pharmacists did their documentation. When I was going through their records, I noticed that, yeah, this patient was obese, very obese, and had a lot of risk factors to suggest diabetes, but is claimed, no, they did a random blood sugar for him, and it was normal. I think it was about 80. Well, I still wanted to know what was happening to this patient. So because there was a documentation and I had access to his phone number, I sent him a message to say, please, I would like to meet with you one-on-one. And then when he came in the evening on his way from work. And apparently he came the other day too on his way from work. So he probably didn't have much food in him that would give them the kind of figure that they were looking for. So I counseled him, I talked with him, I took him through all the risk factors, we calculated the risk, and his risk was a bit high. And then we started looking at how could we bring down this, what could we do to get from one level of risk to the lower one and all that. And by the time we were done, he also claimed that he was not hypertensive, but his blood pressure was high. And he said that was because he was stressed. But I didn't want to go about with that story. So I told him of the need to see a doctor for proper management, and he agreed. Now, where I'm coming from now is I decided to halt it there, even though I could do A1C for him. I told him that I needed to do A1C, but since he said he was going to see a doctor, I didn't want him to spend too much money because they will repeat it there. He said to me, please do it. I want to know what my status is. And that is because we had gone through some processes. He had seen life because we have some charts that are there to show. So he saw the different levels of risk. Because this time around, we're looking at risk for heart disease. And he saw its different levels of risk and what he could do. So we did A1C that night. And interestingly, he was already pre-diabetic. His blood pressure was high. He wanted to do a lipid profile, but I asked him to come back for that. But where I'm going is that documentation helped me to be able to intervene. So we need to improve and look at what form of documentation we can do that will help us to do more than we are doing. Then this is their own referral booklets. We have a referral form that was developed by Association of Community Pharmacists, but not tailored to diabetes. So we can tailor it. We can look at something that will tailor to diabetes prevention and start something in our own environment. So let's look at barriers to diabetes prevention. One is knowledge gap. I just came up with this actually. I just thought through them. Naturally, once there's knowledge gap, then it creates a barrier because people cannot deal with what they don't know. So the knowledge gap can be with the patients themselves or with the healthcare professionals. If we don't know that we should do certain things, then we might not be able to help them to prevent their diabetes. Another thing is the attitude. I put it here as attitude of healthcare provider because it's not just about the pharmacist, though we are pharmacists now looking at us so we can position ourselves there. And one is willingness. We must be willing, we want to help. That desire has to be there. When we are willing, we go the extra mile. It makes us look out for what can we do. And one constraint that we might have is time, naturally. So sometimes it might be necessary to schedule this person for a time where you know you are not very busy. And that is where documentation also comes in. We might just quickly use the younger staff or even the non-pharmacists to check the vitals. And if there's nothing alarming, schedule this person for a time when we can sit down to talk. Then communication, empathy, and skill and other skills necessary. Because the way we break the information to the patients can make or mar. So we need to have very good communication skills. We need to have empathy. We need to have friendship formation skills. We need to have critical solving skills. We should be able to think through. We should be creative. We need to have creativity skills. because every patient is different and unique. There are some people that when you try to let them understand what their challenge is, they are willing to go along with you. There are some people that they can be very nonchalant and you might need a different strategy to get them. And of course, another problem we have is this multidisciplinary collaboration. It's a teamwork. We cannot do without other people. But if we don't have the right attitude towards it, and we think that only us can do it, then we're already creating a problem for the patient. So these are barriers that can come to play in diabetes prevention. Attitude of the patients. And I will say cultural influence. Like I said, some people don't even understand what you mean when you say, do you have family history? I've had cases where they will tell me their stepmother or their father's wife, something like that, somebody that is not directly related. So, and it's because in our culture, the way we see things is different. So we need to look at that that can be a barrier because you may not be able to help the patient because he has allowed the cultural influence into the information is given to you. Then a lot of people are in self-denial. They don't want to hear, no, don't mention it. No, God forbid, for my enemy. That is common too. Then the willingness to change, because if we look at, and I enjoy not to do that, probably later go and study the National Diabetes Prevention Program by CDC. It's a whole year that they allocated to it. And they have different things that they do in the year, all centered around lifestyle. So if the person is not willing, then it becomes a problem because the person must be willing to go through all of that. And another barrier, of course, is reimbursement. You know, the Bible says that a workman is worthy of his wages. Time is money. But the challenge we still have right now is that many people see pharmacy as products, even the services. So all they want to pay for is the products. Many of them are still not willing to pay for services. The system has not built in services for pharmacists. And that is a big deal because sometimes you might spend an hour on one patient to help this patient talk about diabetes prevention and all that, to educate the patient, to help motivate the patient towards positive behavioral change and all of that. And then at the end of the day, nothing comes to you. So it's also a barrier that we need to start looking at and how do we handle it. Then government commitment, like I said, the one I saw for US is National Diabetes Prevention Program. That means that the government is in it. In the UK, too, they have NHS Diabetes Prevention Program. I'm not aware of any national program that we have that can support diabetes prevention in the populace. I'm not aware of one. So what is the way forward? We need to physically look at how do we overcome these barriers. We need to keep updating to break the knowledge gap. And as we get updated, we should also be willing to impart those around us with knowledge, our staff, the communities where we serve. And there are so many ways we can do that. For example, in my pharmacy, we have a WhatsApp group for diabetes patients. And as many as are willing to enroll in there, they enroll. So from time to time, we bring education, information, and we've been able to impart them positively towards behavioral changes. But we also say that some people are not willing to belong. I have some patients that they will say, no, I don't want to be in any group that shows that I'm diabetic. So that's also a challenge, but there are not many. Then the attitude of the healthcare professional, it's important that we build a team. And I know it's doable. As a group, we can build a team of healthcare professionals that we will work with. Individually, in the pharmacy, as community pharmacists, we can build our team. We have built teams over the years. We built quite some teams. Let me say teams because there are many people in our teams. So we have so many people that we work with. Sometimes I do home visits with dietitians. I'll go to visit the elderly with dietitian. I have done home visits with nephrologists before. And we just need to build this team. It takes a lot to be able to do it, but it's doable. So we need to, first of all, believe that it's doable, that we can do it. And then we will go out of our way to make friends. It costs a lot, but we just have to pay that price because we want to achieve something. Anything that we want to do deliberately, intentionally, will always cost us something. Cost us some of our comfort. We need to move away from our comfort zone. I'm hampering on this a lot because we really need to have more collaboration in healthcare to be able to help our people. And it will rub positively on the attitude of the patient when they see that we are working together. From my experience, they enjoy. Some people even come to me to say, Mrs. Lawa, I have this problem. I know that you know who to refer me to. They already know that it's not my case. But who do I refer them to? And then I coordinate the care. Somebody that had a bone marrow problem some time ago came to me to say he wasn't managed in a secondary facility. And then she came to me, she said she knew that she heard that I could connect her with people that would do better with her. And then we were able to get her to see a hematologist in tertiary institution, and we're able to be part of our management. So we just need to build these teams. And then reimbursements, we have to look for a way to get it in. What we have been able to successfully do is to ask them to register at a price. Then when they register at that price, at least that takes part of the cost. And all these tests are not free. So by the time we do A1C, we do lipid profile, we do the various tests in the pharmacy. So some money will come. I know that it's not enough to make up for all that is put in, but if this patient stays with you, then there's a long run benefits. And sometimes they invite other people to come to your pharmacy. It increases footfall. They want something, they are coming to you to get it. So at the end of the day, there's still a long run benefits. But I know we can still do better with reimbursement. And unless we come together as a team to do that, it might be difficult. Government commitment is what will be a big deal. And the way we can do that is to have advocacies. The way we can do that is to start to document what our interventions and the results of our interventions and make publications. And then talk to as many people as possible. I was attended to a lawyer yesterday. I did medication use review for that lawyer. And I was telling him, look, you can help us healthcare professionals. And I lectured him about what each of us stand for. You know, and he was like, that is why they call them learned colleagues, that they have to learn about all the other professionals as well. And we made a joke out of it. But at the end of the day, he was able to see the need for this multidisciplinary management in healthcare. So I will conclude by saying that the role of the pharmacist in screening for diabetes prevention cannot be overemphasized. The pharmacist is strategically positioned to help the whole world reduce the number of people transiting from pre-diabetes to diabetes. Thank you. my references. So I'll stop here for questions.
Yes. Thank you very much, Ma, for this wonderful presentation. Thank you very much, Ma. Yes. While we'll be taking comments, questions from participants. Yes, I would just like to chip in one or two things while awaiting our members to make their comments or questions. I know the presenter is coming from the community pharmacy, so I can see why she's referring to most of our information from the community pharmacies. And for most of us that from the hospital practice, I know we also have one or two information that I want to contribute. So please, if there's any comment, kindly indicate so that I can give you the opportunity to make comments. I can see the co-host, Dr. Olurise. If you have any comments, please. Kindly raise your hand so that I can unmute you. Okay, while waiting, somebody wrote in the comment section that one of the challenges that patients, they have this entitlement mentality towards pharmacists. I don't know, Ma, can you address some of these challenges? Because I know majority of the time, patients believe that doctors is more superior in handling some of these cases. Maybe this is what this person is trying to comment about, that patients have issue of entitlement mentality towards pharmacists. I don't know what's your understanding about this comment.
Thank you, sir. Well, when I read it, it was something that came to my mind, not that they think we are inferior. Well, maybe because I don't have that experience with them generally. But let me start from, since you are the one that interpreted it, let me start from that angle. Honestly, if you stay in your premises or as a hospital pharmacist, you show your stuff, there's no how the patient will think that you are inferior to the doctor. There are so many things that you can do to prove your worth. Like I said, I was in medication use review for this patient. The patient came, he wanted to buy, what is it? Common stem cell. That was what he wanted to buy. That was what he came to buy, stem cell. And because we didn't have anyway, somebody was now, then I took over. And I found out that he was hypertensive. I found out that he had had a stroke before, and he was taking so many things. So I said, sir, that would be harmful. Go home and bring all your medications and let us look at them. So he had to go and bring all the medications, and we started sorting them out. And then a lot of discovery. So that role that I have played, I don't see any doctor playing it. And at the end of the day, he saw, I was able to prove to him that I'm a pharmacist and I'm concerned about rational use of medications. So it depends on how we handle the patients. When we prove, you see, most treatments are centered around drugs, mind you. So there's no how drugs can be taken out. Very few treatments don't need drugs. So we are the center of the case, sort of, after the patient is us. So we can take advantage of that to show our stuff, and they will respect us. As long as we make them understand that it's not about their money. I could have sold them something else to just like that, but no. We need to make sure that it's not harming you. Then, but what I think this person was talking about is this mentality that all they need to pay for is the product, not the service. Yes, they generally have, some of them have that. Or I can also tell you that for those who know our worth, I've measured somebody's blood pressure before. And when we were done, he said, what is your bill? I said, no bill. He said, look, you have done more than what my doctor did. And he dropped 1,000 naira on the table and left. Because I didn't just measure blood pressure. I took him through what is meant. I took him through the risks in hypertension that is untreated. I made him to understand that hypertension will not be cured and all that. And it was like, his doctor didn't tell him all of what I was telling him. I had done more. And I made him sit down 5 minutes, observed all the protocols. By the time we are done, he threw 1,000 naira. I've asked so many of them that I have quite a number of them that are willing to pay actually. So it's true that some of them have this mentality that it's only products. But if you are patient with them and you penetrate them, they will bow.
Yes, thank you very much, Ma. Any other comments? Please, the floor is open for further comments. The time for this program is actually from 8 to 9, but I'm sure we can take like 5 to 10 minutes for other comments or contributions. But while I'm waiting, I would just like to remind us of what the presenter actually, some of the key points of tonight's presentation. She mentioned the need for us to have a similar national diabetes prevention program. So I would like us to actually look through this. She also mentioned the issue of having a pre-diabetic risk test, which I believe it will be necessary for each pharmacist to have this handy. And also, she also mentioned the important role that the pharmacist can play in terms of education, which I believe this program that we have this night has actually addressed some of this. And myself as a pharmacist, what I always ask my colleague is, what can pharmacists do differently that will further promote the image of this profession? And I believe tonight's presentation has actually answered some of these issues. And also importantly, the issue of documentations. I believe as pharmacists, we do a lot of things, but because we don't document some of these activities, they tend to lose. So if I will encourage us from tonight's presentation, and I believe that CPAN has brought a couple of documentation tools that we can use to document some of these activities. So I would also like in tune with what the presenters to actually ensure that we document all our activities. And also the issue of barriers. She has actually also tell us how to go about breaking some of these barriers. So I would like to encourage our colleagues. And also one important information that I would also like to share with us is there are instances that some of these facilities that we find ourselves might not even have some of these testing tools. So as pharmacists, it's good that we know some of the signs of this diabetes, what we call the osmotic symptoms, because some patients will be presenting some of these symptoms. And because maybe at that time, we don't even have some of these kits to run some of these tests. So having knowledge about the osmotic symptoms will also give us a guide to actually probe some of our patients or our clients, like the issue of polyphagia, polydipsia, and polyuria. These are some of the osmotic symptoms. So the time is 9 p.m. I am still expecting any other comments or any other contribution from participants. The floor is open, please. I can see that nobody is raising their hands. I believe that tonight's presentations is actually very understandable and practical, as the presenter mentioned. Maybe that's the reason why most people are not having any question to ask. Ma, I don't know if you have any parting message for us as pharmacists. Any parting message, Ma?
Thank you. Yeah, I talked a lot about collaboration, and that collaboration even has to start with us. You mentioned that as hospital pharmacists, you might not have the wherewithal to do this test. You can refer them, we can work together. And sometimes when we discover problems with our diabetes patient or any of these patients, we prefer to go through the pharmacists in the facility. So There's a lot and a lot and a lot that we can do together. Let us do all we can. I want to challenge us from tonight. Let's even adopt this, that we want to intervene in diabetes prevention, and let's start working at it. We can have a small committee within this group. What materials do we need? Some companies are ready to support. Sanofi paid some of us to do some lectures on this, and they came up with some of these papers. Some companies will support us, so we can just start something. I want us to start something. Let's agree that we will start something on this, and then we can scale it up. Small documentation materials you can do, just simple things, so that maybe at the end of the month you can say how many people we tested, how many people actually were pre-diabetic and all that, how many people came down with it, got values that are diabetes. Thank you.
Okay, thank you very much, Ma. I want to appreciate your time with us this evening for this wonderful presentations. And on behalf of all the executive members of the Endocrinology Pharmacists of Nigeria, I want to sincerely appreciate this wonderful presentation. And all our members, our colleagues that have time to actually join us for tonight's presentation, I want to also appreciate your presence. This is bringing to an end the fourth module of today's presentation. I want to appreciate the anchor and every other person that joined this presentation. Thank you very much. Have a wonderful evening. Thank you, Ma.